the censors that's listed, and they just found this from the Facebook social media group, and they can just sort of roll it.
I'm assuming you're using Red Cat, right?
We actually have another something different, but
Because I know it's coming out of Denver. I work at a cancer center. I do heart cancer.
Oh, terrific.
I'm in clinical trials, so.
Okay.
Very
We'll be happy to talk to you more about any questions that you have, and
All right.
make sure you have Cheryl's contact info.
Another quick question then, have you been looking, other than the morphology of the idiopathic stenosis, any marker studies? Are you banking any of the resected tissue? Is it going central to your central bank? What are you doing?
So yes on all those things. Most of my scientific training is in immunology, so I'm very interested in why this is happening. So all the tissue that gets taken as a biopsy for someone in the study, it gets tracked where we know that a biopsy's been taken. And it doesn't leave the center, so the centers don't have to stress out about it right now. But the idea is that then we have a list, basically, of all these biopsy specimens that when we get funding to do scientific study of the molecular pathways that are activated, they're all there.
So you're planning to use FFP?
So, big spectrum of things. There's a lot of, science stuff we could talk about, fill you in on, but there's a lot on that. I think we're very interested in that. Sure. So, turns out, yeah, you're right. I've heard that too. Yeah, they're terrific. They care passionately about this disease. They, I think they feel like they know how their approach works, and their approach works for them. And they felt pretty secure with their system for tracking how their patients do. So they've been approached several times, and they take care of this unreduced disease, and they take care of this spectacular practice. They really care about that. But they sort of feel like they have their own way to track and stuff. They care a lot about this disease. Right. Yeah. So, like I said, trying to deconstruct some of the problems that we take care of. The people who have an innovation injury, that's a special, unique problem. And you're right, the anesthesiologist and the ICU doctors who put in the 3 diseases they need to know. That is a separate study. That is a separate, approach. That is a separate problem. Something that we're actively involved in, our North American Airway Collaborative, but it's not this one. One of the core study is idiopathic stenosis patients. How do the different treatments work? What are the trade-offs for each one? You're right. We won't make any progress on people who get injuries after breathing tubes without talking to the anesthesiologist and the MIT doctor. We do, and we will. That's next. Question.
Well, my mom got diagnosed with stenosis cancer, and at the same time, she was also diagnosed with thyroid cancer. So, after the treatment, the stenosis got more aggressive. Is it possible? Can it be a consequence of the original treatment, the cancer treatment?
Well, it's probably specific to individual patients. We don't think that thyroid cancer treatment usually does anything to stenosis. But you are having surgery on the front of your neck. There's probably a couple reasons why maybe it made the stenosis come back faster. It's not something that we know about. It's not generally associated with thyroid cancer. So it's a great question, and yes, the answer is yes. So some centers that have the ability to bank as full blood will do that. It's not everywhere yet, but we will. So the genetics are very important, and I think very unique, and potentially very revealing, since everybody's very, very similar. It's, PCORI, what they do is they want to give information to patients so that they can decide today, how am I going to get treated? They don't want to, they're not interested in saying, why did I get this disease? What did it come from? Necessarily, what's molecular biology? That's not PCORI, that's the NIH. So, but we're, have a foot on both sides of the fence, because now we have this study, which is going to tell you, hopefully, at least give you some information about what you can expect with different treatments. And we'll have a list of 600 people with ISTS, where we can call them up and say, would you be interested in participating in this genetic study to try to figure out why? We'll be able to send you a little cup that you spit in. We get your DNA from that and send it back, and then we can tell you, what the genetic, potentially what some of the genetic changes are that predispose people to. That's potential. That's not going to happen without talking to you, but that's what this group allows us to do.
Do we know how many people worldwide might have idiopathic?
Well, it's a good question. I don't know the answer to that for sure. We think probably it's somewhere in the order of 1 in 400,000 we would get this, 1 in 400,000 women. We could try to run the numbers. But I would tell you that almost nobody in Africa, nobody in parts of South America, you get this disease. It's pretty restricted to Northern European heritage people. Not exclusively, but predominantly. So, the actual numbers, it's a good question. That's a great question. It's a great question. I would say, I think it's real fair to ask that. In the United States, I think a lot of people have access to care, especially when they have some kind of emergency. And not everybody has access to the same care. Another whole conference probably. But so at least in the United States, it doesn't seem like there's people who aren't going to be wide care. Yeah, it's uncommon. There are people, a couple in our study, but in terms of the spectrum of the disease, most people are. There's very few diseases that are that restricted. So there's something there that we'll figure out, and it's going to help us take care of each other. And the reason we're going to be able to do that is because you guys are all here. You're participating in this trial, and you want to make a difference. And it's a rare disease, so people are spread out all over the country, and there would be no way for one center to figure it out on their own. So it's really you guys who are figuring it out.
Okay, I had my first resection in 1981. Originally, they thought my problem was the result of an intubation. Then I got pregnant within 2-3 years. My trachea collapsed. Then I had bone graft and failed, and eventually had another resection. Altogether, I got 13 procedures. My doctors were at Mayo Clinic. My original surgeon has retired. 63 years old. I'm told I have Wagner's. I got Fitz disease the first week of my life. And my mother has the same problem. My sister has the same problem. Only theirs is much less than mine. Genetically, I'm 100% an ancestor of Norwegians. So I do not qualify now as idiopathic. So I won't be part of your study.
And I certainly don't mean, I know that's one of the hardest things for me, because I don't want anybody to feel left out. This idiopathic subglottic stenosis is a pretty defined group, and by having a type of people, we feel like we can really make some meaningful insight in that disease. Like I said, these 3 different broad categories of Wagner's or autoimmune disease, post-innovation injury, they are all on the docket. We started with that. But it's a challenge, and understanding, at the beginning, when you were dealing with this, what was going on. Those are the kind of questions. Is it stress? Is it an autoimmune disease? Because lots of times for the autoimmune diseases, and for Wagner's especially, it's really a medical treatment, as the forefront of being able to quiet things down. And there's a lot of new emerging therapies in Wagner's that are really changing lives of people who've got Wagner's disease.
I was 10 years old and I knew I had a stridor. Nobody else in the world knew it but me. Yeah.
Well, it's great that you're here. You've been through a lot. You look great.
I'm tough.
Yeah. All right, I'm going to turn the mic unless any other questions, and feel free to harass me later. I'm going to turn it over to Dr. Lee.
Well, hello, everybody. My name is Christopher Wooten. It's a pleasure to be here. I'm also at Vanderbilt. I am a pediatric otolaryngologist by training. By that, we've gone through ENT residency, like Dr. Gelbart, and then my training, because of my interest in airway, actually took me to Cincinnati Children's Hospital, where it is probably the busiest airway center in the country. Now, as the name would imply, we mostly take care of children. Because it's sometimes hard to find people with a lot of interest in adult airway, we took care of many of the adult airways in Cincinnati as well, and they would be referred in. So that's sort of what got me into this space. And when I came to Vanderbilt, I was excited to get some program going. that is similar in its scope to what you see sometimes from pediatric centers to deal with airway problems. And the initial attempts to get collaboration were not met with success until Dr. Gelbart came along as a fellow, and then we were able to put something together, and it's been great. So we'll talk a little bit about the fruits of that collaboration. But if you have obviously any questions about pediatric airway, I'm certainly willing to talk about that. But I think the interesting thing about pediatrics is we have, I think as a group, developed a little more systematic way to think about airway problems and maybe different specific tools to deal with them. That can be up-translated to the adult world, but in the adult world, there's not necessarily as much systematic reporting I thought about it. If you know that you don't have to do certain things, they may or may not participate in collaborative research efforts, and they may or may not share exactly what they're up to. And so as a consumer, it may be a little bit tougher to find consistency. So I think what we're trying to put together is consistency and a systematic approach to what is a very heterogeneous personal disease. So anyway, what I'm going to talk about today is very simple, and it seems not very complex. I mean, basically, I want to stand up here as a surgeon and go over with you guys some thoughts about how you make decisions regarding treatment of your airway stenosis. What do those decisions involve? What do the treatments involve? And again, I echo what Dr. Gelbart said. Please feel free to stop me at any point. I'd love to talk. I almost wish we had a big whiteboard and some markers up here. I feel like sometimes it's just drawing the problem. It's showing what specifically you're dealing with and how to make tissue work as well as we can to treat your problem. Great example, having two resections and rib grafts. I mean, certainly those are all the kinds of things that are in this airway knowledge base and kind of come out of the pediatric knowledge base as well. But how do you apply them to specific patients at specific times is so challenging to get the best possible outcome. So this is a slide that was echoed from Dr. Gelbart's talk earlier, and actually he was the gatherer of these data, the publisher of these data. Just looking at, in general, two theories of how to deal with a problem with your airway, one being dilation in the blue line, one being resection in the red line. The implication is that, resections are, as he said, commonly performed, dilations are commonly performed, maybe not too center specific, pretty easy to get through as operations go, but at the same time, things tend to come back. Whereas resections may offer some people permanent cure, but also with the caveat that nothing may be permanent. There may be the tendency to get better for a while, but also get worse over time for a variety of reasons. And what I'm going to talk about really sort of spans both idiopathic laryngotracheal stenosis as well as acquired laryngotracheal stenosis. I would suspect, and I don't know, many of you in this room probably don't exactly know what the initial type of injury was. Was it an idiopathic that sort of was intervened upon and became an acquired? Was it truly an acquired because I know I was healthy until I had that myocardial infarction or until I had that car wreck that took me in the hospital? There's a lot of different things, and certainly some males in this room with stenosis, and we would tend to think that's probably not going to be, an idiopathic stenosis. But at the end of the day, once things get advanced enough that you're starting to think maybe endoscopic is not going to serve my disease, then it really becomes a very personal questioning of your plumbing and how can we fix it. So you go to a center and you get a dilation. Most centers now are doing not only dilation, but usually some sort of augmentation of that dilation with maybe an injection of medication. That's what that little needle floating into the voice box there is supposed to be doing. And then afterwards, and often before dilations, some array of medications are being used to try to suppress inflammation, suppress bad bacteria, support good things happening in the airway, and trying to prolong the good effects of dilation as long as possible. And some of you guys may have been placed on any number of these drugs, antibiotics like Bactrim, or azithromycin, inhaled steroids like Pulmicort, maybe Cromolyn, just depending on really what your treatment team feels like is the best thing for you based on biopsies, based on lung washes, based on reading the papers that are written, based on a sense of gestalt, trying to figure out how to maximize your duration. But, what do you do with traditional endoscopic treatments with the additions of medicines is seeming to become ineffective for your disease in the first place, or just burdensome? There, you're in the OR too often. So like Cassie was talking about, where she was getting a year between treatments, then all of a sudden she was getting a few months, and all of a sudden she's getting 8 weeks, and at that point you're starting to feel like that's a lot of going to the operating room 6 times a year to try to stay alive. So if you get to that point, then really what you need to do is get evaluated for the feasibility of an open operation to deal with your problem. And feasibility, I think, is a key statement. It's a loaded question because people are not just their laryngotracheal problem. People are very complex with a lot of comorbid factors and conditions that we need to fully understand as much as possible to get the best possible outcome. So in the pediatric world, since really 2001 at Cincinnati Children's, where I trained, there's a concept of an aerodigestive center. So the idea that there are places where in rooms like this, practitioners would sit, 40, 50 practitioners around a big table and discuss child after child after child with stenosis coming in and out of the system. There was input from pulmonary medicine, lung doctors, GI doctors, ENT doctors, speech pathologists with expertise in swallowing and voicing, people with expertise in how feeding goes but needs to go through an alternative method. They would all sit in rooms and run through these patients over and over. And we would take them to the operating room, we would scope them, and we would figure out from a multi-level airway and aerodigestive model what all's going on with this patient so that we could try to make the best possible treatment decision for them as they move towards something kind of more dramatic like a big airway surgery. And interestingly, while it is a well-replicated model in pediatric care, again, there's not a lot of that in the adult world. And so that was one of the neat things that Alex and I are very proud of that we've been able to start at Vanderbilt is an aerodigestive center for adults. And why does aerodigestive matter? Well, basically the implication is that if you have a airway problem, a stenosis in your subglottis or between your vocal cords, but you have a very broken esophagus with active allergic disease or active reflux disease, or you have lungs that are aspirating and full of bad bacteria that are not going to affect healing well, or maybe an airway that's not very open above the voice box because of advanced sleep apnea. Those are things you probably would want to know about and fully grasp and understand and regulate and optimize as much as possible before we take you to the operating room for 3 to 6 hours of your life trying to do something dramatic to your airway. We want to make sure it's going to heal as well as possible. And we certainly get no guaranteed outcomes, but I think this model tries to provide the best possible outcomes, and I think we've been able to help a lot of people that otherwise would seem not as likely to heal as well as you'd like. So in the bubble, are the core people: laryngology, Dr. Gelbard, pediatric trained person, myself, interventional pulmonology, a guy named Otis Rickman, who takes care of some of the tracheal lesions, is an expert, absolute Jedi in pulmonary care and dealing with stenting within the airway, and a phenomenal fleet of great speech pathologists who understand voice, who understand swallowing, who understand in the hospital rehabilitation as well as what happens as an outpatient. And then an array of people around us that we're consulting and working very closely with, be it physical therapy to optimize one's physiology before surgery, or weight management, which is often very important in how sleep apnea happens in adults, working with sleep medicine, and the list goes on and on. But the core group is listed right there. And all this is really just helping to figure out what is your aerodigestive disease. And these are just a lot of pictures of clinical care that I've been involved with. But just to sort of show there's radiology, there's working up with scans and images and MRIs, there's getting biopsies and seeing what kind of stuff is growing at the cellular level. There's kind of coming up with models of one's airway and how best could be splinted or stented or augmented or resected or whatever. And then doing the work of the operation. And all that really kind of comes down to staging your disease, much like you would stage cancer. If any of you, hopefully none of you have ever dealt with anybody with cancer or yourself with cancer, but I'm sure you have, and that word staging is commonly described to try to get your head around how bad is my loved one's disease. What are their odds? Are they going to do well or not? Are they in a good place? Are they in a tough place? And staging the airway, I think, is an important concept involving both the anatomy of the airway, like the little glossy picture of a voice box there, seeing what is the nature of the disease, how tight, how small, for how long, how many segments of the airway are involved, and then some sort of physiologic staging. We got at the top a picture of some bacteria, trying to figure out what kind of bacteria may be on the surface, what kind of bacteria may be getting past the voice box and down into the lungs, getting tissue biopsies, again, seeing what kind of cells are there causing inflammation that we might be able to give medicines to suppress, and drawing some lab work, trying to determine how inflamed somebody is when they come to the clinic, how prone are they to probably not heal well, maybe heal great. And some of these data we've been able to put into some graphs that kind of display some differences between populations. I'm going to wager, okay, that is a wager. So, for one thing, here we got this group of idiopathic subglottic stenosis versus those who acquired it after an intubation from a car wreck or a heart attack or something like that. And on this axis, the chart shows what's called the Charlson Comorbidity Index. Basically, it's just mathematically kind of summing up how many other bad things you have associated with you that, you know, kind of would put you at a higher risk for not doing great in general, like, you know, stents in your coronary arteries or bad diabetes or having a history of stroke or things like that. And it's just a really neat picture showing that most of the people with idiopathic subglottic stenosis that we treated initially, at least, had effectively no significant comorbid disease. They're pretty healthy folks coming in with just bad airway breathing problems. In contrast to this group that did have that bad car wreck and that bad hospitalization, and they're 18 months out and still trach dependent, as it turns out, they have a lot of problems that usually go along with it. And those things are really necessary, I think, to understand as we go forward with treatment. Another graph here just displays the day they walk into clinic. How inflamed is somebody? So you think about, what does that even mean? Well, it kind of means, you know, when you feel like you're, you know, you got a cold, you got the flu, you got shaking chills, and your muscles are aching and everything. You have a lot of inflammation in your body. Your body's actively spitting out a lot of chemicals that are maybe trying to fight, you know, bacteria and viruses, but they're also somewhat harmful. And we wouldn't want to operate on somebody if they had flu, spitting out all these chemicals trying to fight the virus. But some people walk around this earth with lab work that looks like they're actively, you know, infected with flu and trying to fight it off. And again, if you look at that number, that's kind of what this number depicts here. People with acquired disease can have really high numbers indicating active inflammation the day they walk into clinic, even if they would say, well, gosh, my injury was 20 months ago. Whereas this value here is showing that today you seem really agitated at a cellular level. And then there's some other differences that we have been able to tease out. Dr. Gelbart mentioned height. Another measure of how one is shaped is body mass index. So as it looks like people with acquired disease maybe have a little bit higher body mass index compared to idiopathic disease. And sometimes that also means that they may have a higher tendency towards obstructive sleep apnea, as well as traditional voice box and tracheal kind of problems. And then we also record data on the things we have done, what's working, again, we'll look retrospectively. You know, this is doing graphs and resections on people who are 60, 70, 80 years old, trying to see what works, what do we do, how do they swallow through the reconstructive process, because we know it's not just about obviously getting a better airway, but the voice box and the airway also helps us speak and helps us swallow safely, so you want to make sure you're going to get through that. The good news is, to cut to the chase, if you swallowed well before surgery, you're probably going to swallow fine after surgery. And so all these data, all these considerations, all these scans and labs and everything we're putting together, meeting families trying to figure out what's the right thing for you. And really what it kind of comes down to is a few key questions. Is your problem above the voice box? Is your problem involving the voice box primarily, particularly the vocal cords, which are really the most challenging part of it? Or is your problem below the voice box? Or is it really a combination of all the above? And spoiler alert, sadly, a lot of times it's all the above, or it's at least a couple zones. And so it's, you know, the ideal treatment is not going to be simple and discreet for most people, and that's why a lot of you guys who have had bigger surgeries will have stories that do not include, you know, I had this done and I was completely finished and I never had another tough day of my life, because usually there are other levels that are still having to be dealt with. So if your problem is really above the voice box, you may be a very winded, very unhappy person that has trouble, and particularly at night when our natural body's muscle tone in the throat relaxes. And as we go to sleep, things want to collapse in, but sometimes you need to perceive that during the day, or you'll be the person that, you know, the wife sitting next to you on the couch says, this guy snores when he's awake watching TV. You know, that's the kind of upper airway obstruction that a lot of people will also bring into clinic in addition to a traditional voice box or tracheal kind of obstruction. So this video you're watching, for those of you who can see it, it's called a drug-induced sleep endoscopy. So it's kind of a pioneering way to look at what levels of obstruction occur in somebody, particularly at night, that contribute to their obstructive sleep apnea. Is there anything you can do about it surgically? And so these are the kind of things that we do in children who have had their tonsils and adenoid down and still have a hard time breathing at night. And these are things that have been done really for many years, starting in Holland, about the last 20, 25 years, in Europe and more in the United States, to look at the same thing in adults who struggle with obstructive sleep apnea. What you're looking at is the throat getting further and further down towards the voice box. And the take-home point is, it really doesn't look that open. You see a lot of pink stuff collapsing in, and the camera getting obstructed by tissue at every possible level. This patient struggles. And so how did you treat that? Well, most adults going to be on CPAP. And many adults who had a bad heart attack that resulted in intubation were on CPAP before they had their, big event, and now they're trach dependent. But part of being the trach out is going to be dealing with the stuff up here because, they're not going to be entirely better by fixing their trachea with the upper leg collapses as well.
It's crazy.
Drug-induced sleep endoscopy. So abbreviated DICE, D-I-S-E. And Dr. Gelbart and I are trying to do more and more of this as we put people to sleep as well. It's significant. That you may still have residual disease, is that, or does OSA predict idiopathic? Yeah, I think we would probably say biologically the two may happen, but probably are not related. I will say this, obstructive sleep apnea in children is rated as about 2% of the population, adults is rated as about 10% of the population. And every year, the incidence of obstructive sleep apnea is plummeting in the United States. We're looking for more. People are living longer, people are living differently, people with syndromes that may populate that group. And honestly, I have a stroke. I've had a sleep study. I don't meet the typical criteria. I don't have a large neck size or a BMI that's elevated, and yet, my wife will confirm that I do.
When I was 13 years ago, and I was considerably thinner, but then I started developing other breathing issues which affected my overall everything in my life. But the sleep apnea has not gotten any worse, but then my breathing got terrible. But I've always wondered, is there some relationship between the two? So maybe.
It doesn't seem like it at this point, but I will say there's not a relationship, but there's oftentimes a co-occurrence because sleep apnea is just so common. It's kind of like finding, a thyroid nodule or some heart disease in somebody. And eventually, you live long enough, that sleep apnea is going to be a chance occurrence in many individuals. So problems at the voice box. Again, you're going to the operating room trying to decide, is this patient's voice box problem because of paralysis of nerves? Maybe they had a thyroid surgery and nerves aren't working correctly. Is it because of stenosis or scarring? Joints are kind of fixed together. And you're literally going to go down there as a surgeon and feel these areas. You're going to move the joints around. You may want to do what's called laryngeal EMG if you're worried about a paralysis question versus a stricture, a stenosis, a scarring question. So that's just what these are depicting. Every, I think, big operation is going to be preceded by a trip to the operating room, trying to understand how thick, how long, how firm, how scarred, how does it move? All those questions need to be answered about the patient's airway from really stem to stern before you come up with a comprehensive multidisciplinary plan. And then, so the illustration that we just saw there was a picture of an airway that was not moving, and the air didn't move because of paralysis. This is an example of an airway that is affected with dense scarring. So this is a technique that we've developed to endoscopically open the airway and put some tissue in there to expand it. With the advantages of working through a natural opening mouth, but at the same time getting a more dramatic expansion of the airway than simply dilation would ever allow. So this is called an endoscopic rib graft. If you don't like gory pictures, I apologize. I see you're kind of turning away, so maybe I'll just move on. But it's stuff like art to me. I love this stuff. If your problem is really below the voice box, a tracheal problem, then traditionally, besides dilation, you have three major options. One of them is to put some piece of cartilage there, a graft surgery. One of them is to basically cut the trachea in half and overlap segments, so that's called slide tracheoplasty. And then the most commonly employed option, a resection. You just simply cut out the bad piece of pipe and you hook the good pieces of pipe together, and that may extend all the way up to the voice box, so that's called a cricotracheal resection, or maybe just down to the trachea where it's a tracheal resection. And that's really kind of it. You sort of think about, okay, I've got, I heard about, 4 or 5 different surgeries. They all have nuances. They all have personal, individual changes that we would make for your anatomy, or any surgeon would make for your anatomy. But in general, those are the ways people are going to think about it. And then you may have heard something about, okay, I selected my surgery. Now I want to talk about some sort of stent. I don't know if anybody's ever heard of a stent, but I'll tell you a little bit about that just because I think it is a mystical and often irritating part of healing, but it may be a necessary part nonetheless. So the whole concept of surgeries that you'll read about in the literature a lot of times describe a term of single stage versus double stage. So single stage means you got some surgery on your voice box or your airway and you left the operating room without a trach. Obviously that's a desirable outcome for everybody. Nobody wants the trach. The whole point of these big operations is to get the trach out in most instances. But in many cases, single stage operations are not possible in children, and they may not be possible in adults as well, and even higher incidence, because it just sometimes takes a long time to heal these surgeries. But oftentimes a single stage operation applied to adults would be those things like resections, where you cut out bad stuff, you put good stuff together, and you leave the operating room with the trachea that was a disease in the trash can. And you get out of the OR and you're kind of done. You're going to heal from there. Versus a double stage operation where you actually leave the trachea to protect the airway as it heals, and you've done so much stuff to the voice box level that you're going to want to leave a stent in to make sure that things are going to continue to stay open and heal in an orderly fashion. And so stents can take a lot of different stripes. This is called a suprastomal stent. It's a stent that goes across the voice box, pokes out around the epiglottis. These are stents that are designed to kind of sit around the vocal cords, and there's even stents that are designed to float down in the trachea. Just showing kind of how they look schematically, I think is an important drawing, because this is probably the one drawing I find myself doing the most in clinic when Alex and I are talking to families about operations, is you have a trach, you'd like to get the trach out. We think your problems are above the level of the trach, at the voice box and the subglottis. We're going to do something there that sounds kind of fancy, and we want it to hold open for a while, so we're going to put a stent in that's going to literally sit above your trach, open through your voice box. What that means is, while that stent's in place, you're not going to do a lot of talking, because how do we talk? Air comes out of our lungs, goes around our trach, and comes out of our vocal cord. So if you have something stuck in there, like a big lipstick tube holding space in there, you're not going to talk about it. Likewise, when you try to swallow, all of these things naturally close down in people to protect their lungs from having food and liquids go down the wrong pipe. With that stent in place, it's going to feel weird to swallow. So that's probably the most, and finally, you know, the airway is the airway. It's the conduit to get air in and out of the lungs. And with that stent in place, you're not going to be able to breathe but with the trach, because it literally is like you inhaled a giant tube of lipstick and it's sitting down your windpipe. So stents are great, but stents are tough, and that's probably the most important take-home point. They will stay in place for weeks, sometimes they'll stay in place for months, if you do a lot of work on the airway, and it's going to take a long time to heal. Many airway surgeries require no stenting. Only a few require stenting, but if you're putting in things like grafts or doing a lot of complex rearrangement of tissue, this may be the reason that your surgeon has selected to use it, because we think it seems to help, but it does come at a cost of some irritation for a while. And so I think I'm going to close on a case, basically, just to try to illustrate some of these points, because this person, in this case, may be like many of you in the room. So it was a case of a 60-year-old female who had pretty common stuff, some allergies, got diagnosed with asthma, had a asthma workup, and got on some albuterol inhalers, like many of you have been on albuterol inhalers, and it didn't really seem to help. And then eventually saw somebody who took a look at the airway and found that there was stenosis. There was narrowing of the voice box. Sounds like it probably was an idiopathic stenosis, meaning that there wasn't a history of an intubation injury before that. But they got some treatments, and unfortunately the treatments, while successful at some levels, were damaging at other levels, and that may have a lot to do with just how their body healed. So again, they come to us now with the trach in place, can't get decannulated, and they have an airway that looks like this. So this is not a gory picture. This is just looking down the voice box in somebody, showing that the vocal cords are kind of stuck shut. If you can imagine, here's where I got to get all my breathing done. It's just a pretty tight space. But you get beyond the voice box level, you get down to the regular tracheal level, and things actually look, you know, all in all pretty good. And that's just kind of showing a pretty stiff scar. So, you know, this patient comes through our clinic. We think about what are those treatment options, endoscopic things. Can you put some grafts in through the mouth? Do you need to open the neck to put some grafts in? Could you take out scar and just throw it in the trash can? Do you need to put a graft in and take out scar and throw it in the trash can? All those are the kind of options you have to weigh. And for her, just because of the nature of her disease, where the scars went to, we decided to put a graft in the front and a graft in the back. This is a very traditional operation to apply to a 3-year-old. She's 6. Excuse me, she's 60. You know, she's got 57 years on the typical recipient of this operation. So you got to make some adjustments. You have to expect that the rib tissue is going to be different. It's more bony than soft. The airway is going to be different. It's more bony than soft. And the healing is going to be different. She hasn't built new blood vessels in 60 years. And so, you know, it's going to take a little bit longer for things to stick in place. So we put the stent in for 8 weeks. We take the stent out. Things look nice and open, but you don't ever give high fives all around, take the trach out and send them home and never see them again, because we know an adult takes still a while to heal. And even on that day, we see, despite the fact that things look pretty open, there was a couple areas where the graft looked a little questionable. And then even 11 weeks out, the graft had a couple questionable spots. And then eventually 6 months out, things started looking pretty good. Started to talk about getting the trach out. And in the distance, finally, everything is now settled down. The trach is out, the airway's open. But all through that, there were a lot of necessary trips to the operating room to guide the healing process, to respect the fact that adults take a long time to heal, and you do not ever want to turn somebody loose to their own devices when there's an opportunity to intervene and keep pushing their airway in the direction that it should go. And we actually put a stent in this lady for a while further down to kind of open up the tracheal part. A lot of injection, dilation, a lot of prayer, a lot of wringing of the hands and nursing it along, and eventually she did well. And I think that, you know, the results that are quoted in the pediatric literature for an operation like this are going to approach about 90% success rate of getting the trach out in one operation. In our experience, we probably suggested in the adults, you know, it's not that high. It's probably closer to, you know, 70%. And I can show you sub-segment groups of people who are 60 to 80, people who are, you know, 30 to 60. But at the end of the day, everybody's an individual. Adults bring a lot of unique comorbidities. You can do these surgeries, you can help a lot of people, but the grafts we started with, the statement I end with is, you know, there's a lot of complexity, a lot of nuance to get the outcome that you want. So that's all I got. If you have any questions, anyone? Yes?
If we're not able to come to you all the way to Vanderbilt, is it possible for you to work as consultants and to consult with a treating physician in your GI center, or is it better to come for a consult, an assessment, and a staging, and then relay the treatment plan with a local treating physician?
Yeah, it's a great question. So if you didn't hear it, you know, the question is, if you hear something that you like, should you travel to a center, or could you get things done locally? I think the truth is, thankfully, this country is blessed with a lot of good doctors, good hospitals that are distributed geographically across the country. There's some areas that are probably tougher to find folks that do a lot of open surgeries. Finding somebody who's very comfortable and very good at endoscopic dilation kind of things isn't quite as difficult. As Dr. Gelbart said, it seems like these open surgeries probably do matter a little bit on volume. You don't necessarily, you know, if you can avoid it, maybe be the only one done in the last 10 years at wherever you go. Maybe it'd be nice to have, you know, some experience where you are, just because it's tricky. And seeing a lot of these, seeing how they look, you know, 9 weeks out, seeing how they're supposed to look 4 months out, I mean, all those things kind of come with practice. We're always very happy to talk to referring physicians and relay information back, and sometimes we do find that even state payers may say, look, I like what you're saying, but you know, my gal's from North Dakota, and we're not gonna take that Medicaid to Tennessee or to, you know, Ohio, where Dr. Lorenz is. You know, so it may be that we will work, you know, just kind of intellectually as consultants, and then they still may find that it's better through some petitioning of the insurance, the third-party payer, we can get you to the center that you want to be in.
And are there any place where you can look up easily the numbers of these kind of procedures so you can assess what centers are closest to you who are doing this procedure? I'm driving 3 hours to see Dr. Lorenz, so I don't have anything really local either.
Right. And honestly, though, as vast as this country is, a 3-hour drive to get to Dr. Lorenz may be pretty reasonable. I mean, I hate to say that, but yes, absolutely, because we know Cleveland Clinic's got a great volume. I use North Dakota as an example. There's got to be, I mean, I can't even imagine it's a 3-hour flight to get somewhere, probably to have, you know, a place with a lot of experience. Yeah, it's tough. The literature is not super opaque. I mean, super clear on that. I think you can read papers and sort of intimate somehow that these folks must do a lot because they're writing about it. That's probably one good way, is to go to the scientific literature. Reputation.
The way I identified was because I found your clinical trial, and I'm thinking if you're participating as a PI of a center on an observational clinical trial looking at this, you obviously must be practicing, and that was practice you wouldn't be, accruing. So that's the only data I was able to find
Yeah.
that would give me any indication as to where I could possibly go for treatment.
Is there anybody here not from the United States? Okay. Where are you guys from? Oh, okay. Okay, yeah. So one thing I will say, Ecuador. It seems like in the United States and Canada, it's pretty intuitive. Academic medical centers, those involved in teaching, those that are the University of Toronto, the sick kids, or the Cleveland clinics, or the Vanderbilts, or Mass Eye, whatever. I mean, those places usually have a pretty full complement of practitioners to deal with a lot of problems, and there's a good chance that they will have a skill set in this, or at least they'll know how to direct you. Incidentally, it does seem like in Latin America, oftentimes the greatest talent is outside of the medical center. I think the payer system is a little bit different. I think a lot of times I've interacted with airway surgeons from many countries, in Mexico or Argentina or Brazil. And it seems like honestly you'll maybe find sometimes the quality outside there, but I think the reputations nonetheless are visible. And the guys in the academic centers are going to say, well, this is where I would send you. That's good. And honestly, I will say, this is not actually a disease that a lot of people want to treat. Open airway reconstruction in adults is, it's tough, and it's a lot of dealing with long healing process on really what we would say is the most important organ of the body. I mean, if you can't breathe, you really don't have much quality of life. And so I think people hopefully will always be very forthright and say, look, this is not in my wheelhouse, because they don't want to deal with something that is going to be very burdensome and get an outcome that they're not proud of. So.
For those of us who have taken multiple dilations, do we need to worry about the repeated anesthesia?
It's a great question. It's a really apropos question in the pediatric world, because we're starting to finally get to the point where we see the effects of anesthesia on the brain and the developing brain. And the good news is, I guess there's so many effects of anesthesia, right? You talk about cognitive effects of anesthesia. At the end of the day, still the most important things about anesthesia that predict a bad outcome are really things that are in the room and not under necessarily your control as a consumer. I mean, if you can have things done awake and have a good outcome and still avoid anesthesia, you've avoided anesthesia. But it turns out the drugs aren't as important as blood pressure and oxygenation under anesthesia. So again, if you're at a center that does a lot of dilations and you've already had successful outcome, and it looks like you're here asking great questions, the truth is they probably are doing a very good job of managing the critical functions of blood pressure and oxygenation while you're asleep. And that is a challenge in airway surgery, because we have to share the space of airflow with the anesthesia doctors, whose purpose it is to keep those numbers looking good, and the beeps are all at the right tone, and we have to occasionally take that out and dilate and get the tube back in, and it's a key relationship that the academic medical center will probably have ironed out very well with their anesthesia providers.
I have suprachoroidal, which
That's pretty unique, yeah.
Is a resection an option, or is that mainly treated with dilation and injection?
Yeah, so for those of you who didn't hear her, she sounds like you have above the vocal cords stenosis. That is a very unique condition. That is not a resection condition. Resections really work in the big tube of the airway, the trachea, where you literally can take chunks of that tube out and you still have some tube left over. Not to say that there's not something else that could be done in the reconstructive mindset, but I have to say that's probably the most challenging of all the areas. Because I'm sorry, I know. Because the issue is there's not a lot of structure around it. So wherever there's structure, you can sort of build on structure. Yeah. Well, yeah, and without knowing much more about the details, I'll just say that probably no to a resection, but there may be some other things that one could do. And I would leave that to, I don't know if you guys want to weigh in. Not seeing what you look like, but yeah. Please.
I mean, it's a very good question. I would say, you know, the bigger question is, well, you know, how do you do research and how do you make it meaningful? How do you find any insight in what's happening? You know, a lot of centers that have 8, 9, 10 people, it's pretty tough for them to know that anything that they see is important. The other thing is that there's not animal models. You know, you can't make an animal have idiopathic subglottic stenosis, so it's hard to know. And there hadn't even been any tissue culture reagents, you know, sort of cell lines or something for patients. So those are all sort of fundamental tools that people need to understand, you know, how estrogen's playing into it. So most of the things that people have been able to do have been able to define what treatments work for people, you know, so far. So cryotracheal resection, dilations, those, you know, we can tell that those work and help people. You know, now that we have this group, we're starting to dig into some of those questions where we have these specimens and we're starting to understand the circuits that get activated for ISGS patients, and then we can think about, well, why do they get activated? You know, what's the role of estrogen in all this? I would say that people looked at estrogen, progesterone receptors in the scar itself. That's one thought. You know, maybe the estrogen, progesterone act on the scar and start things from scarring. And there's not that many there. You know, most people don't have estrogen, progesterone receptors in their scar, so it's not acting directly on their scar. So it's probably acting, you know, either on the immune system. We know that estrogen and progesterone really interact with the immune system. People who, when we're born, there's an equal incidence of asthma in men and women, boys and girls. Somewhere around puberty, it switches though, and the more severe asthma really affects women, and it's really driven by estrogen. People have shown. One of my collaborators, you know, has done that, you know, pretty recently. So estrogen really can affect the reactivity of the airway and how it responds to insults. And so that's probably part of what's happening for women. Estrogen also actually really thins out the mucociliary lining of the airway. So when estrogen's high, that lining is really thick and viscous, and that may play some role in trapping particulate material or bacteria or allergies. That's another theory. So those are sort of the main elements people are going on. I would say, you know, most people are kind of trying to focus on the activated circuits right now, just because we can't stop you from being a woman. But we can maybe turn off some of these circuits. I mean, there's certainly people who are working hard to try to understand, you know, all these questions that you have. Because they're good questions. There's an answer out there. No, you're right. And that's also part of a lot of the questions in some of the natural history study in these surveys, to try to understand people's estrogen exposure. Are they taking estrogen and progesterone? Have they had a lot of kids? You know, have they had no kids? Standard questions that we know from the kind of OBGYN literature impact your estrogen exposure and your incidence of estrogen-driven cancers. You know, that's one thing we're looking at too. So you're right. Mm-hmm. It's, you know, all good questions. You know, and I think there's for sure a role for estrogen and progesterone in what's happening, and people are trying to sort of work that into the study that they have going on now. Sure. There's a question about what's the role, is anybody investigating the role of estrogen and progesterone in idiopathic subglottic stenosis since it's so many women? And I'm saying, the short answer is yes, people are. I was saying some of the challenges to why so many of these things that seem very obvious, basic questions, everybody looks the same, what's going on, why hasn't anybody explained it yet? It just was born out of the fact that it's a rare disease, it's sort of strung out across the country and the world, and that some of the tools that we typically use in science to try to unravel things, even if they are rare, don't exist for this, where you don't have an animal model, you can't make a mouse get ISGS, and we didn't even have cell lines, so you could look at cells and see how they do. So those are some of the reasons that it sort of slowed down. Just excuses, but basically people are looking. The other thing that I'd say though, then it gets a little blurred, because people who have a breathing tube put in very frequently are women also, and women probably have a smaller, or do have a smaller trachea and larynx than men. So when that same breathing tube goes into men and women, women are probably more predisposed to getting injured, and so that's probably why women are preferentially affected even from having a breathing tube in. It also could be estrogen that kind of interferes with their scar, makes their scar worse, but that's probably part of it a little bit too. Sure. That's a good question, and certainly some people probably feel like laser does do that. It's certainly talked about. I would say one of the, yeah, sure, sorry. So some people want to do repeated dilations, or the use of laser during dilations predispose you to having more of a tough time with the resection. And I'd say, certainly a view that's out there, and some people feel like that is the case. As far as the number of dilations, probably doesn't impact things dramatically. Mass General had a series where a lot of patients they looked at had resection, and most of them did well, and a lot of people who had laser treatment before didn't make any difference. So, most of the evidence that I've seen so far is that, laser treatment doesn't negatively impact your resection.
Do you have plans, or are you already looking at medical treatment, looking at different protocols immediately post-procedure, and autoimmune treatment, if the Wegener's
Sure.
approved?
Yeah, no, they're good questions. So some of the things that different people do around the country afterwards or before, we're looking to see if that makes a difference. Do those people need less dilations or, do better? And then we'll be able to dig deeper into what those regimes are, the antibiotics or steroids, and do they make a difference? And at the same time that we're looking at the molecular circuits that get turned on, it raises new opportunities to try to interact with them, kind of the same way that they do for autoimmune disease. So maybe someday we'll be able to treat this much more medically like we do Wegener's, and we will need less dilations or less open surgery. That would be the hope. We could find something else to do.
Does stress play a part in this?
I think stress plays a part in everything. I think everybody perceives their disease, in their own way, in their own life, and it definitely does. Does it drive stenosis? No, but, does it make you feel short of breath and make you, impact your life? Definitely. So that's something that's part of our study now is, try to understand how the disease sort of affects your full life, as opposed to just the peak flow values or CT scan or what it looks like when we look in there. How's it affecting you to help us tailor our treatments and make sure we're doing everything we can. So one thing we feel like that peak flow meter does is maybe take a little bit of the stress off. It gives you an objective measure of how much air you're moving. So all those times you kind of wonder, am I breathing worse? Am I not breathing worse? Maybe I just need to get looked at. At least, we feel like, well, maybe you can use that peak flow meter and say, okay, it's the same as I was last week, the week before, so I can feel pretty good about where I'm at right now, so I don't need to sort of stress out as much.
Are you looking at autoimmune deficiencies such as IgA?
So, we're not specifically looking at IgA deficiency, but we are, investigating some other diseases that we wonder if overlap with this. And like I said, there's a lot of efforts underway to see how this is similar or different from Wegener's disease. ISGS is similar or different from Wegener's disease. So a lot of people, realize that there's an answer out there. This is something that we feel like, seeing who the patients are and how they do, there are answers. It's just no one's looked yet. So now we're looking. Well, hey, Cheryl, will you raise your hand? We need to applaud Cheryl, too. She's worked so hard for everybody in our college. Stand up, Cheryl. Stand up, Cheryl. but they're also like $10 at CVS. So something we're looking at. I think that, you know, it certainly hasn't been reported yet that it's elevated for people with idiopathic cyclic stenosis, but across the board, we'll see it pretty frequently. And I think it just tells you that it's not just a localized process. It's not just a scar in your throat. Your body's angry at something, and it's being felt everywhere. You know what that is? You know, we're still working on that. I think that's what you can take away from the high-sensitivity CRP. The way we use it, you know, in the context of what Chris was talking about, evaluating people with airway problems, is that somebody with a high sensitivity CRP, you'd be much less inclined to try to do a big resection or do a big interaction with their airway. You do everything you could to maybe calm things down, steroids, antibiotics, you know, other medications to try to tone it down a little bit. That's sort of how we use it.
In your experience, at what point do you either recommend or do you see patients going from dilations into resection?
It's a great question. You know, I think everybody asks that same question, but everybody answers it differently. But it's probably a pretty, you know, personal decision. You know, most of the time the dilations work for people. It's just when that gets to be too much of a burden for some people, you know, they want to change. I don't know that there's a right answer to it. You know, it's sort of an individual decision for everybody. Some people would say 6 months is, you know, it's not too much of a crimp on my life. Some people would say I can't live like that. Some people are fine with once a year. Some people would say I don't want a dilation anymore. I don't want to have a chronic disease.
I would just add one thing to that. I think if your treating physician is showing you photographs maybe after the surgery or maybe as you follow up with her or him in clinic, and you see, or they're telling you that you're starting to have a vocal cord involvement, what they would call glottic disease, because glottis kind of refers to the space between the vocal cords. It would be very nice to try to keep your disease in one zone. That actually markedly simplifies treatment. So somebody else earlier asked, you know, do a bunch of dilations make resection more difficult? And I would say probably not, as long as the disease that has been dilated is staying exactly where it started. You know, Kessie's story, which of course I don't know the details, you know, but at the same time, it's a story of an evolving problem where it started in one zone, and through the process of treatment, it became involving other zones of the airway. And I think as long as you have an isolated subglottic problem, you have a disease that can be cut out and that can be removed, and hopefully you'll have a pretty good outcome. But once it starts to involve the vocal cords, the movement of the vocal cords valves our airway, it protects us during swallowing, it is a voice generator, and most importantly, it's a conduit for airflow. And so once that starts to be broken, then you can't simply resect your way to good. And oftentimes that's where you have to start to consider doing other operations, depending on what you believe in and what's in your bag of tricks, you know, to try to expand open the voice box. And the outcomes are never going to be as good either, because once, Dr. Gelbart said earlier, once the voice box, the vocal cords themselves are broken by scar and by fixation, we cannot, at this point, unfortunately, release that scar or reanimate. We don't have the total hip replacement for the little vocal cord joint. So once it's broken, it becomes a much more difficult pathway one has to walk between, you know, open enough to breathe, but not so open that you are completely unable to talk and pouring everything that you drink into your lungs with, you know. And that's a tough place to be.
Okay, I need to take a break. Let everybody go to the bathroom, get some water, get some more fruit, get some, they're bringing in snacks soon. Before we start, I want to make one announcement. We're going to have focus groups for the patients who are part of the airway study. So there's lunches out there that are sponsored by Vanderbilt for the focus groups. So please, and those aren't until later today. So please don't go out and grab a lunch box that's out there. Before we take a break, I want to do 4 raffles. So we get your raffle tickets out. We want to give out some prizes.